Welcome to the Living Well Beyond Cancer series. Today's topic is cancer-related cognitive decline. Thank you for joining us today. My name is Erica Gordachon, and I'm a cancer rehabilitation speech-language pathologist specializing in cognitive therapy at Kessler Rehabilitation in Saddlebrook, New Jersey. I'm excited to be able to talk with you today on the topic of cancer-related cognitive decline, as this is one of the most prevalent side effects that I treat in patients associated with their cancer treatments. Cancer-related cognitive decline is an area that has been reported in the cancer research for some time. However, researchers are now just starting to understand what causes these cognitive challenges and why. Today's talk is going to focus on what cancer-related cognitive decline is and how cognitive therapists can help address these challenges. Cancer is a journey, and we recognize not everyone's path is the same. Everyone starts their journey in a different place. Your age, your beliefs, your support system of family and friends, your general health or well-being, among other factors that contribute to how you are starting your journey. Also, your destination may be different. Where are you aiming to go? Your destination may be finishing treatment and putting cancer behind you. It may be living with chronic condition, managing adverse effects to lead as normal and independent life as possible. Your destination is working toward your goals and care. Once diagnosed with cancer, your path may take you through a variety of different choices: surgery, chemotherapy, targeted therapy, radiation, all of which are customized by your cancer care team to meet your needs and get you to your destination. With each specialized treatment, adverse effects and intensity of adverse effects may vary as well. The tolerance to treatment will be impacted by your general well-being, where you started your journey. Our team wants to help you prepare and keep your motor running smoothly throughout your journey. So before I get started talking about cancer-related cognitive decline, I wanted to start with a little activity to test your cognitive skills and prime your brain for the information I will share with you about cognition. I have on this slide a list of 10 words. I'm going to give you all 1 minute to do your best to try and remember these words, which I will then place back up at the end of this presentation. So take some time to remember these words. So let me dive into the term cancer-related cognitive decline. This is the term that is now being utilized for patients with cognitive decline related to cancer. What research is showing is that cognitive impairments are not just related to chemotherapy, but from a variety of potential causes. Also, the term decline is being utilized as sometimes changes are so mild, they are not considered as an impairment in the objective sense. However, these mild changes can really impact a person's everyday function. Here are some potential causations for cognitive decline. I say potential as people affected by cancer may or may not see cognitive changes related to cancer or its treatment. Cancer and its treatment can cause the body to initiate an immune response. This response, while important, can change signals known as cytokines, which can increase the risk of cognitive decline. Chemotherapy can be toxic to nerve cells in the brain, causing CRCD. There's some research that also supports a potential increase in cognitive decline after a stem cell transplantation, especially immediately following the transplant. Immunotherapy, as it is newly developed treatment approach, research in this area is emerging, but there is some correlation of immunotherapy and CRCD. Radiation, especially any radiation to parts of the central nervous system, such as the brain and the spinal cord, can result in cognitive decline. Specific hormone therapy, such as aromatase inhibitors and tamoxifen, work to reduce estrogen-positive breast cancer from utilization of estrogen to grow, which can cause cognitive decline, as estrogen plays an important role in brain function. Cancer-related fatigue is one of the most commonly reported symptoms. And as we know, when we are tired, it makes it much more difficult for our brain to function, which can also result in decline. Lastly, stress and other psychological factors, such as anxiety and depression, especially during the treatment process, is so common. And these things can have a direct impact on cognitive functioning. Here are some numbers related to the prevalence of CRCD in cancer survivors. 30% of people with CRCD report cognitive changes before cancer. We discussed on the previous slide that prior to treatment, cognitive impact may be related to the increased cytokine levels, or in other cancers, it can be related to tumor growth in the brain. 75% of people with CRCD report cognitive changes during treatment, which is highly likely because of the treatment side effects, especially cancer-related fatigue, stress, or illness like nausea or headache. 35% of people with CRCD report more long-term effects, months to years after treatment. These long-term effects can be related to cancer and other neurotoxic effects of treatment. As I mentioned earlier, not all patients will have long-term cognitive changes. So what are some potential risk factors or red flags that may increase the possibility to CRCD? This is a great figure that shows how there could be multiple factors, as well as potential risk factors that can contribute and cause cognitive decline. Some risk factors may include age, severity, and/or the type of cancer, lifestyle, such as exercise, diet, and smoking, as well as specific genetic factors. Allostatic load refers to the wear and tear on the body that accumulates when we are exposed to repeated or chronic stressors. These stressors can be internal, external, or both. These are some quotes from my patient, Joan, on her first day of treatment with me. She was a 45-year-old woman who was diagnosed with estrogen-positive breast cancer. She came to me 1 year after completing active treatment, which included a double mastectomy with lymph node dissection, chemotherapy, radiation, and was continuing on an aromatase inhibitor. She had returned to work as an accountant, had 2 teenage children with busy schedules, and was struggling to get through the day. Some of the things she would say to me when she started were, "I constantly get stuck on words," or "I keep forgetting what I have to do by the time I do it." For example, when cooking, she would read the next step to the recipe, but when she went to the ingredient, or she would forget what she had to do with it next. Now that you have an idea of what causes these challenges and what patients are reporting, I'm going to move into the specific cognitive deficits that are most common with patients with CRCD. Here are the typical cognitive complaints heard from patients reporting cognitive decline as per the American Cancer Society. They include attention, memory, executive functioning, word finding, and speed of processing. These are known as cognitive domains, which are different ways the brain works to allow us to perform our daily activities and maintain relationships. In the next few slides, we'll do a brief review of some of these definitions and the functional impact you may see in your everyday life. Let's start with attention. I usually start with attention as this is the foundation for all cognition. Attention is the ability to focus our awareness on a given stimulus or a task, to concentrate on it long enough to accomplish a goal, and to shift our awareness when needed or alternate our attention to something else. We need attention to focus on information coming in. So often, people may think they're having challenges with memory, but more often it stems from difficulty with attention. For example, with misplacing things, like your car keys or your phone, it might feel like memory because you don't remember where you put it, but it's due to our attention. Think about it. When you first walk into the house, you're thinking about the next thing that you have to get done or greeting family members, not thinking about focusing on where you're putting your keys down. Some other examples of attention difficulty include sitting through an entire movie, following conversations in more of a dynamic environment, or shifting back and forth between reading a recipe and preparing a meal. Speed of processing is another commonly noted challenge for people affected by cancer with CRCD. Speed of processing is the pace at which you take on information, make sense of it, and begin to respond. So in other words, how long your brain takes to process information it takes in. Speed of processing can impact many things, including challenges in conversation, listening in at a doctor's appointment, or learning new information like new instructions at work. Memory is the one area that I probably hear the most often. As we discussed on the previous slide, this can be related to issues with attention, or it can be related to any one of the 3 steps of the memory process. The most commonly impacted area of memory is the first step, the learning and encoding stage. More specifically, working memory. Working memory is our brain's mental blackboard, our ability to hold on to information and manipulate it. I usually describe it to my clients as imagining your working memory looking like a conference-sized table, where you can neatly organize and hold on to multiple piles of papers or information, manipulate them, and find them quickly. After you begin to notice cognitive changes to your brain, your working memory can feel more like a small desk, like you might see in an elementary school, with less room to organize piles of paper and information. And as you start to move things around, information can start to fall off. In other words, you're still able to hold on to information, but maybe not as long as you used to or as much as you used to. For people with working memory challenges, they may remember important pieces, but may drop others. After information is processed into our working memory, it's then consolidated and stored. And lastly, when we need the information again, we pull it back out through the retrieval process. Executive functioning is one of the most common seen challenges in patients with CRCD. Executive functioning is basically the brain's CEO. So when you think about what a CEO does for a company, they help organize, manage, monitor, plan, and anticipate potential challenges. This is what our executive functions do for our brain. These are our higher level thinking skills that make us human. So people with challenges with executive functioning may have difficulty tracking or estimating time, might have challenges with initiation or getting started, or setting realistic goals. They might have difficulty managing their schedule. They might have difficulty with organization or trouble with problem solving. Lastly, they might have difficulty with mental flexibility or being able to see other ways to get things accomplished. Word finding is another commonly reported challenge with patients with CRCD. Patients will report difficulty thinking of the word, saying, I know what the word is, but it doesn't come out, or it takes longer to get it, or the word is on the tip of my tongue. Sometimes these challenges can be so subtle that they may not be noticeable to other people, but is very much a challenge for the people with word finding difficulty. I have worked with high-level executives saying that they're avoiding giving presentations now as they're afraid that they'll have difficulty thinking of a word while presenting to a large group of people. It can be very distressing. I want to bring you back to Joan's story so I can share what treatment looked like for her. Joan started with a comprehensive cognitive evaluation where challenges in working memory and executive functioning were identified, as well as difficulty with cancer-related fatigue, further exacerbating her cognitive symptoms. Her working memory challenges explained why she was having difficulty remembering what she wanted to do when it was time to do them. with things like cooking and paying her bills. Executive functioning explained her challenges with multitasking and organizing her to-dos and priorities. Now that we have reviewed the most associated cognitive challenges people affected by cancer with CRCD face, I want to address an important concept called cognitive reserve. A person's capacity to maintain a normal cognitive function in the presence of brain pathology. This concept came about when researchers were trying to determine how some individuals, whether it be Alzheimer's disease, brain injury, stroke, Parkinson's disease, or CRCD, may not be so impacted as others by changes to their brain. What they found is that patients with higher cognitive reserve were found to be less impacted cognitively than those with a reduced cognitive reserve. So if you had two brains that were looked at after death, they would look the same physically, but we know that the people could have lived very different lives. One could have been completely independent in their lifestyle, while the other required a lot of assistance to remember things or take care of themselves. The only difference here will be related to cognitive reserve. Cognitive reserve is attributed by age, occupation, schooling, new learning, and exercise. What we also know is that cognitive reserve is modifiable, and there are things you can do to improve your cognitive reserve, starting today. What we do know is that a person's cognitive reserve can be modified throughout life. So, what are some ways you can work on your cognitive reserve? Exercise is one of the best things you can do to improve your cognitive reserve. For those of you who are not able to attend our previous Living Well Beyond Cancer series presentation regarding pain and fatigue, the presenters also reviewed how exercise is beneficial to these areas as well. Opportunities for new learning. New learning is how neuroplasticity happens. We need to keep exposing our brain to new things and new activities. Brain stimulation doesn't only have to mean doing computer games, but it can mean anything like learning a new language, trying a new recipe, taking a class, learning an instrument, or even listening to this presentation. Improving your nutrition. Nutrient-dense whole foods are best. Finding ways to reduce stress like meditation, yoga, journaling, or support groups. Finding opportunities to socialize and engage in your community via volunteer work, seeing friends, family gathering, meets and greets, and support groups. And lastly, individualized cognitive therapy, which we're going to dive into in the next few slides. So when should you, as a patient, consider cancer rehabilitation to help with cancer-related cognitive decline? If your challenges with cognition is interfering with your function and your ability to do daily tasks or work, cancer rehabilitation can help. How can a cognitive therapist help your cancer-related cognitive decline? An evaluation by a speech-language pathologist or an occupational therapist that specializes in both cognitive and cancer rehabilitation provides a comprehensive assessment of your specific cognitive challenges and their impact on your daily functioning. An evaluation may include questions to get to know you, like what was your prior level activity, what were your goals, and what would you like to be able to do? A cognitive questionnaire, which helps determine how you experience your cognitive challenges and how it impacts your daily activities. A health and social history review, which helps determine other potential contributing factors to cognition, such as fatigue and distress. Cognitive testing in the areas mentioned in this presentation: attention, memory, executive functioning, word finding, and speed of processing. A therapist will design an individualized treatment program for you, which I'll go more into in the next slide. Therapy will also include training and compensatory strategy, other ways in doing things to help support you, like memory aids, organizers, and smartphone applications. This will help you manage the symptoms of CRCD. Cognitive therapy, along with all cancer rehabilitation therapies, is extremely patient-centered and focused, meaning there is no cookie-cutter approach. Treatment will focus on areas of challenge for you as the patient and develop treatment activities to improve your functioning, as well as train you in the use of compensatory strategies specific to meet your needs. Some examples of compensatory strategies could be use of an external memory aid, like smartphone applications, or use of a planner and alarm systems to support memory and executive functioning. In my sessions with Joan, I helped her to identify a system to organize her crazy schedule of work and family life, as well as her daily to-dos. This system helped her out tremendously and helped to free up her attention and working memory to do other things like cooking without having too many things rolling around in her head. Therapy will also include participation in cognitively stimulating tasks and identifying tasks that you can do at home to continue to stimulate your brain for optimal cognitive reserve and brain health. For example, with Joan, I worked with her in using computer applications that targeted her working memory and her organization. Lastly, we know that cognitive changes can be related to a multifactorial reasons, including fatigue and stress. Therefore, therapy will address these issues as well by providing education on energy conservation techniques or helping you refer to other members of the cancer care team that can support you. Joan also had challenges with cancer-related fatigue. I was able to get her started with one of our physical therapists to generate a home exercise program for her to help with her fatigue and improve her cognitive reserve. At the end of her time with me, these are some of the things that she said now. I finally feel back to myself. And when I get home from work, I can actually do things now. So here is a good example of how cognitive therapy can improve a patient's quality of life. I hope that Joan's story helps paint a good picture of how therapy can help. One of the best things you can do is utilize strategies to help reduce your cognitive load, or in other words, lessen the amount your brain is holding on to. This in turn will free up your brain for improved attention and organization. You can do this by writing things down in planners, calendars, or notebooks, but I highly recommend using something that you will always have with you, not just something at home. Using smartphones is a great way to do this, as most of us have our phones on us. Some great apps for organization and memory are Cozy, Microsoft To Do, and Google Keep, which is one of my go-to ones that I recommend to a lot of my clients. This is a snapshot of the screen. It's set up like Post-its, making it easy to see. You can organize information by labels for things like work, bills, medications, and an added ability to add alarms to each note as reminders. So before I move on to our next slide, I want you to try to remember those 10 words that I showed you at the beginning of the presentation. Now, grab a piece of paper and a pen, and let's take a few seconds to write down as many of those words as you can remember. Okay, so ask yourself how you did. Most people can remember 5 to 7 words when fully focused on the list. But now that you understand a little bit more about cognition, ask yourself some questions. Was my attention there when she showed me the list, or was I distracted by something else? Did I use my executive functioning and come up with a good strategy to remember those words? Could I hold on to only the words at the beginning because my working memory couldn't hold on to any more? Now we get to see how all the parts of cognition come together. Thank you so much for your time today. You can find out more information on our program on ReVitalCancerRehab.com. We hope to help you live well beyond cancer.
Thank you, Erica. That was absolutely great. And I'm not going to tell any of you what I scored on remembering all your items, but I might need some strategies. um, so we're just going to do a live Q&A. If anyone has questions they would like to ask Erica live, please put them in the Q&A box. They are anonymous, and we will be able to speak to those for you right now. Erica, I know you work in New Jersey, and you've been doing this for a long time. How can you tell the difference between what is normal aging and CRCD?
That's a really good question. That's a question I often get from a lot of my patients. I think one starts with a little bit of a misconception about aging. I think people are very concerned with my aging brain. Oh, I'm having difficulty because I'm getting old. Well, really, if looking at what we now know about cognitive reserve, if you're keeping your brain active and you're exercising and you're eating well, your cognition really shouldn't start to decline, right? Mm-hmm. So the best way to really be sure, we talked about finding a cognitive therapist or somebody in your area who can do a full assessment and take a look at really what's going on and be able to give a full cognitive evaluation to see what might be aging or what might be maybe related to some of cancer, changes due to cancer and its treatment.
Yeah, I would, even as an OT that does cognition, I think that's one of the number one questions that people ask. And people get very, rightfully so, concerned about memory. Is this something, here's our next question, is this something that can get better, or is this just something I should live with?
So it absolutely can get better. And I think the best thing I tell my patients when they walk into my door is that, first of all, this is something that does happen to people after cancer and its treatment. So just one, starting with validating and just understanding that this is something that is normal and can happen. That in itself can make people feel a lot better. Two, strategies. We talked about, right, starting to use strategies. We use strategies every day, and that's how our brain functions. Our brain quickly understands where we have difficulty, and we start to apply strategies. We start to figure ways around things. So we can definitely help as cognitive therapists in identifying those strategies. And then last, that piece on cognitive reserve, we can continue to make our brain function better by stimulating our brain, by providing our brain with the right healthy ingredients like exercise, nutrition, reducing stress. So yeah, absolutely. This is not something you have to live with. There's definitely ways to make this get better.
Yeah. How, just out of interest, how long did you treat Joan for? How many, over what time frame?
That's a great question. So I saw Joan for about a little over 2 months. Okay. And I saw her about 2 times a week. But she's somebody also, after she was done, I had her come back about 3 to 6 months later. And, just to have a check-in and make sure everything was going well, we did a reevaluation and she was doing great. So not only do, I just see people during that time period, but often we'll have people come back and just make sure that they're doing well. The strategies are still upholding because life changes, situations change, and sometimes those therapy techniques that we worked on might need to change because maybe you got a new job. Maybe you have new expectations in your life. So in her case, when she came back, she was still doing quite well.
Right. I love that story. How long does it generally take to see changes after starting cognitive rehab?
So as I said, sometimes that first session, my patients are leaving feeling significantly better. One, the validation. Two, we can start to chip away at some of these difficulties. So it depends. It could be that very first session you start to see changes. Sometimes it's within a week or two. But really, it's the cognitive therapy gives you the ingredients to help your brain continue to get better and continue to progress, and for you to understand what's going on with your brain as well.
Yeah, education is always such a huge part of any cancer rehab process. Validation and education and individualized strategies. Okay, I'm going to read this one because it's a longer one, so bear with me. I was a SLP and worked with populations of all ages, then was diagnosed with metastatic stage 4 breast cancer at 49. My difficulties with memory are destroying my marriage. I no longer work and I'm having trouble communicating. I use strategies that I used to teach people, but it's not easy and they're having difficulty driving. Appointments are difficult to get. Is anyone doing this therapy via the internet? I live in Washington. And by Washington, I think they're going to be saying Washington State, but I will say this, we have a great program in Washington State. You would go to our website, ReVital Cancer Rehab, and we'll put it up on the screen at the end. You can put in your zip code and that will bring you to your closest clinic. I believe you do tele-rehab, Erica, correct? But it's
Absolutely.
very dependent on the state, correct?
That is correct. So yeah, for tele-rehab at this point, yeah, Washington State. Okay, good. Yeah, so as Kiersey said, there are people in that state that do provide tele-rehab. It is dependent on whether or not we have a cognitive therapist in that state. So that's something that we can definitely help assist you with. And again, as Kirsty said, you can go onto that ReVital website and take a look to see what therapists we have available. I can also just find out for you as well, specifically who we have in that state that could provide cognitive therapy. Tele-rehab is dependent on the state. So in order to treat, you need to live in that state. So for me, I live in New Jersey. My license is in New Jersey. I can only treat in New Jersey. If it was up to me, I'd be treating everybody across the country, because I know there's other people like you who are looking to find people. But now that tele-rehab does exist, we really do have a lot more options out there. So don't feel like that you're stuck by any means, because I hear what you're saying, and I wish what you said was the first time I've heard that be said by other people, but it's not. So there's definitely ways to improve those difficulties and develop strategies around some of those difficulties that you're having.
I will also say at the end, I'll go over a phone number that any of you watching can call and leave a message. And that will make sure as well that it will be routed to a ReVital program director in Washington State, who can follow up with you and help you navigate those issues. Here's another question. Can you take medication to help with CRCD?
So I would definitely recommend talking to your doctor. So for anybody who is having difficulties with CRCD, the first step is to talk to your doctor about the difficulties that you're having. There is some research out there that some medications can help with patients who have CRCD. So it could be something like taking an attention medication similar to Ritalin, but it doesn't have to be. There's many different ones out there that can help your attention and your focus a little bit better, but that is going to be very dependent on you and your doctor to make that determination. But there are some medications out there that have been known to help patients who've had CRCD.
I've got a question for you, Erica. I know you said exercise can help. Do you know what type of exercise is best?
That is a really great question. That's one I get all the time. Well, so any kind of exercise is great, right? So if there's a certain kind of exercise that's going to make you more likely to get up and exercise, go with that. If you like playing a sport, play a sport.
Right.
But what I would recommend, the best opportunity to do, is working with a ReVital physical therapist, or a therapist who specializes in cancer rehab, who can help you come up with a nice individualized exercise program for you. So the therapists are trained in not only physical therapy, but in cancer. So they have that great understanding of those dual diagnoses and being able to generate a specific home exercise program that's going to meet your needs. So that's really what I would recommend to start with. And then even something as simple as walking. So any way that you're just getting your body moving.
Agreed. Is there a time frame? Is there any point in someone's recovery where cognitive rehab is not helpful, Erica?
I have to say no.
Right.
I only because there's going to be times, listen, there's going to be times in your journey where your cognition might be worse than others, right? So your cognition is probably going to be at its worst as you're going through treatments. As we talked about, you might be feeling more fatigued, you're feeling worse, you're nauseous, the stress is high. So all of those things are going to make your cognition worse at that point. But having good cognitive therapy, having ways to work on your cognitive reserve to keep your brain healthy. So as things keep coming your way, your brain is ready to, for lack of better words, fight them. And also you have some strategies in place to help you, because we also have to live our lives as we're going through cancer and its treatment, right? So having those strategies in your back pocket, or as I call it, a nice toolbox of strategies, of things that you can use to help alleviate all of that cognitive load your brain is holding on to, is really ideal. So yeah, having a cognitive therapist, no matter where you are in your journey, I think is helpful.
Agreed. And that, I think that sometimes surprises patients, that they might be, a little further out than others, and they really do think that this is how they're going to live their life. And then it's really rewarding to see someone's actually functionally change, their quality of life change. And just sometimes it's like you say, after the first session, you can just see a weight lifted off people's shoulders. So it is really rewarding. Do you recommend anything to help with stress and anxiety?
So there's a lot of really great research-based techniques that have been shown to help reduce stress and anxiety. Things like meditation. I think, years ago, meditation was considered a little hokey, but now we have tons of research that actually backs it. Meditation for anybody is really helpful in helping to reduce stress and anxiety. So there's great apps out there that can walk you through meditation. I know a lot of support groups throughout the country offer some meditation groups. Journaling is also another one that's really been shown to help reduce stress and anxiety. Support groups. So just having the opportunity to talk with other people who are going through something similar to you can help reduce stress and anxiety. And then always, finding a psychologist or a therapist who can help you talk through some of those things would be my other suggestion for any stress or anxiety as well.
And I think as hard as COVID has been, a lot of things are now, like cognitive rehab or support groups, are available virtually for people. So it is easier for people to access some of that support now than perhaps it was in the past.
Absolutely. Yeah, very good point.
How do you recommend educating family members and friends on the difficulties I am having with CRCD?
So I think that's a really great question. A lot of patients will come through my door and say, I'm having difficulty, but my family is just kind of downplaying it because they might not notice it in the same way that you do. So it could be, as we talked about, so mild that for you, it just kind of throws off your normal daily routine and your structure, but you're still able to, get through the day. So for family members, sometimes they're not seeing it. And being that they've just watched you go through such an incredible journey, to talk about something else, being wrong can be hard. And sometimes, unfortunately, family members can be a little diminishing of other people's feelings. So one, this will be on the website afterwards. So this would be a great video to show them. It's, it's 25 minutes, just have them have a good understanding of what CRCD is and help them understand that this is something that is absolutely real and can help them understand some of these difficulties like attention and memory and how they can show up every day in your normal functioning. And then there's also, handouts available. If you do get into cognitive therapy, I often spend a lot of time with caregivers and just helping to educate and provide that education to them as well. So they have a good understanding of, the memory difficulties that you're having and maybe why you keep asking the same question again and again. So it can sometimes help alleviate that stress in your household if the caregiver feels like they're understanding some of these difficulties that you're having as well.
Do you sometimes recruit the family members to sort of help reinforce treatment plans with people or strategies? Because I know that I do that a lot in my practice as well, just reminding them, validating, but letting the family members know sort of how they can help. Because I think most people want to help, they just need to understand.
Oh yeah, absolutely. And, I think strategies are wonderful, but I think the hardest thing about strategies is generalizing them and remembering to use them and making it a habit, right? We know that it takes our brain, any brain, 6 months to make something a habit. So you might have every intention to want to use an external aid like I showed you during that presentation, but to remember to do it and continue to use it, right?
Mhm.
That's the harder part. So if you have caregivers on board, if you have family on board, these are things that you can, these are resources that you can use to help you make those things habit as well.
Yeah, agreed. How do I know if I'm experiencing depression or CRCD?
So there is some links to having some cognitive difficulties with depression. There is some people who report difficulties with memory and attention along with depression. The difference between these two, with depression, that you're going to see, a lack of initiation, not wanting to participate in things, a loss of feelings or feeling more sadness. Again, this would be a great time where you talk directly to your doctor about some of these things, right? So talking to your doctor about how you're feeling. Sometimes when they're really having difficulty figuring out what's going on, they might recommend something called a neuropsychological evaluation,
Mhm.
where they'll have you have a neuropsychologist give you a full evaluation to tease out really what's going on. Is it a depression or could it be CRCD? So but typically with depression, you're going to feel a lot more emotional changes than you would with maybe CRCD.
Yeah. We've got another question. At the end of my chemo, radiation, and immunotherapy, my mother and now my sister had and have Alzheimer's. I sometimes worry that my memory loss could be related to that. My oncologist says my memory will come back. I hope so.
So just to start, there is no correlation between cancer and its treatment and Alzheimer's disease, right?
Right.
So a lot of people are scared that if I have had cancer and I've had treatments that I'm more likely to get Alzheimer's. That's not the case. Now, I can't tell you if there's a different thing coming your way that has nothing to do with cancer and its treatment. And again, that's where your doctor comes in. And you need to continue to watch for your progress, right? So if you feel that over time your memory is getting worse, and typically with CRCD, we're seeing mild changes, right? But if you're forgetting things that are more significant, like your children's names, right? So it's more of that, what we call long-term memory type difficulty. That might be a time to then talk to your doctor a little bit more, maybe going to see a neurologist who can help you determine what's going on. But when it comes to cancer and its treatment, there is no correlation, or if you have CRCD, there is no correlation with that and Alzheimer's. And I think that's another thing that people often come when they start to notice some cognitive changes. If they're mild, more than likely it's related to cancer and its treatment, not Alzheimer's. Alzheimer's is going to be a more significant change.
Especially, I would assume, Erica, if the onset timed with the cancer treatment.
Correct. Absolutely. Absolutely.
I think we're getting towards the end of our questions, but we have another one, and they're asking, is this different than Chemobrain?
So the word Chemobrain has been used for a very, 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 very long time. And what they now know is that it's not just related to chemo. So they're moving away from this term Chemobrain, because back in the day, they thought anybody who's having difficulties, it's related to only the chemotherapy. Well, what they now know, it's not just the chemotherapy. It could be related to cancer itself. It can be related to stress, fatigue. It can be related to radiation. It can be related to a multifactorial reasons for having this change in your cognition. So Chemobrain is what we call the old school term. And now we're calling it cancer-related cognitive decline, because it's really more related to all these other potential causes, not just chemotherapy. Sometimes we have people who've come in and noticed changes who've never had chemotherapy.
Right.
So it's important, to know that it's not just related to chemo. And hopefully that term Chemobrain will slowly start to go away, and we'll start to just hear this term cancer-related cognitive decline a lot more often.
Yeah. Would you say at the moment people are using them a little interchangeably? I still see a lot of Chemobrain out there.
Yeah, I think Chemobrain is used more often than anything else. I mean, doctors, medical professionals, most people still call it Chemobrain. But I think over time, given the research, given, conversations like this, we're going to start to see a change, I think, in how we're viewing this term. So Chemobrain will hopefully not be around much.
Yeah. Well, listen, we're going to end the questions there for today. Thank you so much, Erica. That was a fabulous presentation. I think some really useful information. And for all of you who would like to perhaps find yourself a ReVital therapist, or would like to watch the presentation again or show it to a family member, you can register for our future presentations, watch past presentations, and locate a cancer rehab specialist on our website. That's www.revitalcancerrehab.com. Or you can call the nationwide number 844-473-8485. Our next presentation in the series will be in December. Look in your emails for details, but we're going to be doing a presentation on navigating the holidays. We appreciate your time today, and we ask that you look out for us on social media to stay up to date on new information, new resources, inspirational stories, and any upcoming events. We hope you found today's topic valuable, and we look forward to helping you live well beyond cancer. Thank you.